we're going to talk about atrial fibrillation. So AFib is a very important rhythm to understand and recognize because of the increased risk for stroke. So let's talk about the characteristics of it, nursing interventions, and treatments. Okay, so if y'all remember, the SA node initiates the impulse, goes down to the AV node, the bundle of His, the right and left bundle branches, and then the Purkinje fibers. So in atrial fibrillation, there are multiple cells in the atria that are initiating a disorganized electrical impulse across the atria, causing the atria to quiver at a rate of 300 beats per minute. So because the atria is quivering, it is not able to contract. And so if it's not contracting, less blood is going to the ventricles. And because the atria do not contract, blood just sits here. So blood pools in the atria. So guess what happens as blood sits there and it pools in the atria? It clots up. So if this blood clot were to go down to the ventricle, and then when the ventricle contracts, it sends it straight to the brain, it's going to cause a stroke. People that are in AFib are 5 times more likely to have a stroke compared to somebody in a normal sinus rhythm. So this is why it is so important for us as nurses to identify the rhythm as soon as possible so we can take action right away. So let's go back to this. Just like an A flutter, the AV node, because it's so smart, it prevents 300 impulses from getting down to the ventricles because we don't want the ventricles to contract that fast. However, some of these impulses do get down and the ventricles may contract at a heart rate greater than 100 beats per minute. And so we call this AFib with RVR, or rapid ventricular response. Think about that for a second. If I have rapid ventricular response, so my ventricles are starting to contract faster, there's less blood for them to pump out, so the cardiac output will be significantly decreased. So let's break down the characteristics of AFib and do the 6-step method. So in step 1, we got to look at the rhythm. And we got to find out, do we have a regular rhythm or an irregular rhythm? So let's count some boxes. From here to here, we have about 21. From that one to this one, we have 5, 10. We have about 14. And here, let's say we have about 12. So the boxes between the R waves are inconsistent. That makes our rhythm be irregular. In step number 2, let's count the heart rate. But because we have more P waves than we do QRS, we got to count both. However, because our patient is in atrial fibrillation, it is very difficult to identify the P waves. If you look at this strip, there's no way to tell which ones are P waves or not. With AFib, people have a wavy baseline where the P waves are supposed to be. Remember that in A flutter, they have like the sawtooth appearance. Well, with AFib, they have the wavy baseline. So again, it's difficult to count the P waves. So let's count our ventricular rate. And we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11. And because we have a 6-second strip, we multiply by 10 and get 110 beats per minute. Now, the 1500 method is difficult to do because of the number of boxes in between the R waves. So when you have an irregular rhythm, the best thing is to count the apical pulse for a full minute, and then you'll have an accurate heart rate. For now, let's use the ventricular rate of 110 beats per minute. So I would say this patient is an AFib with RVR. Now let's do step 3, and that would be the P to QRS ratio. Do we have one P wave followed by one QRS? And because there are no obvious P waves, it's hard to determine if we have a 1-to-1 ratio. So we would call this not measurable. In step 4, we got to do the PR interval. And again, because there are no identifiable P waves, this would also be not measurable. Step 5 would be the QRS complex. So let's do this one from here to here. So we have about 2 boxes. So that would be 0.08 seconds. And that would be within the normal range. And then in step 6, it would be to identify the rhythm, and it would be atrial fibrillation. So let's recap the characteristics of AFib. Number one, the rhythm is going to be irregular. The ventricular heart rate can vary. It can be low, it can be fast, it can be normal. If it's greater than 100, we worry that they are in RVR. The P waves have a wavy baseline. They don't, it's very difficult to identify any P waves. You just see a very wavy baseline where the P waves would be. And the P to QRS ratio is not measurable, again, because there's no identifiable P waves. Same with the PR interval. And the QRS complex is usually normal. So because AFib can cause significant complications, let's talk about how to manage it. Okay, so most patients with AFib, their main signs and symptoms are palpitations, fatigue, lightheadedness, and syncope. These are usually because of decreased cardiac output. This is because the heart rate is going so fast. So nursing interventions for AFib are to determine if it's chronic or acute. If I have a patient with chronic AFib, that's okay. Let's just continue to monitor them as long as their rate is controlled. Got to make sure that they are not in RVR, because that way I know that their cardiac output is adequate. Other nursing interventions would be to obtain a 12-lead EKG to always confirm the rhythm. If it is a new onset, then we got to restore them back to a normal sinus rhythm as soon as possible. Other things that we must do, whether it's chronic or acute, we got to watch out for any signs and symptoms of stroke because of how high risk they are for having a stroke. Remember that the atria are not contracting, so blood pools in the atria. This blood clots up. If the blood breaks loose, then we have a stroke, which is why it's important for them to have anticoagulants to decrease the chances of any clots from forming up in the atria. So let's talk about more therapeutic managements. So the therapeutic managements for AFib are to assess the patient. Again, find out if it's chronic or acute, are they in RVR, and assess for any signs and symptoms of stroke. If I have a patient who is in chronic AFib, we monitor them. We got to make sure they're taking the right medications and anticoagulants. Let's say I have a patient that's a new onset AFib, and they come into the hospital and their heart rate is in the 150s. So they're in RVR. Because this is going to decrease the cardiac output, they are going to be unstable, and they are also going to be very symptomatic. So I got to take action immediately and try to convert them back into a normal sinus rhythm. Priorities are to control the ventricular rate. Usually we put them on beta blockers or calcium channel blockers. In the hospital, we start them on a cardizem drip or amiodarone drip. This helps try to convert the heart rate or slow it down tremendously, so that, again, the heart rate is controlled. If this doesn't work, we got to do a cardioversion. Now, if I have a patient, again, that comes into the ER, unstable, symptomatic, heart rate of 150, and they are not taking in any anticoagulants, I have got to be careful before I do a cardioversion. Because if they are not taking anticoagulants, and I cardiovert them, guess what I'm going to do to that blood clot? I'm going to break it loose if I convert them to a normal sinus rhythm, because the atria is going to contract properly, the ventricles will contract, that little blood clot will break loose and go straight to the brain. So in order to prevent that, patients have to have a TEE, a transesophageal echocardiogram. So here's my patient. And a TEE, we basically stick a tube down their throat, into the esophagus, and through ultrasound, we try to see if there are any clots in the atria. If the patient has no clots in the atria, great. We go ahead and cardiovert them to convert them back to a normal sinus rhythm. If they do have any clots in the atria, we do not cardiovert, because you don't want to break that clot loose. So that's why it's imperative to always find out if patients are taking an anticoagulant. Now with ablation, so if somebody has had a couple cardioversions and they're still in AFib, we can do an ablation. And make sure that you guys check out the A-flutter ablation lesson, because I talk about that into more detail. But just in simple terms, ablation will burn the cells that are causing the additional conduction, the additional stimulus. So only the SA node initiates it, and the patient will hopefully be in normal sinus rhythm. Now, again, I cannot say this enough, whether it's acute or chronic, can't spell, acute or chronic AFib, patients have got to be taken anticoagulants. Another example I want to share is if I have a patient, the same patient comes into the ER, comes into the hospital, new onset AFib, symptomatic, unstable, and we have them on a cardizem drip. I have got, more than likely, they're going to be started on a heparin drip. And this is going to prevent the risk for clots forming in the atria. Patients will go home on some anticoagulants. Usually Coumadin, Eliquis, or Xarelto are the most common ones. But they are initially started on a heparin drip. Sorry, I can't spell. Heparin. Initially started on a heparin drip until their anticoagulants are therapeutic. So always advocate for your patient and make sure that they are taking this if they are in AFib. So the key points regarding atrial fibrillation are to understand the abnormal characteristics of it. The atria is quivering. It is not contracting. So there are no identifiable P waves. There's a wavy baseline. Looks something like that. Okay. Wavy baseline, no identifiable P waves, and the rhythm is irregular. These two right here are the biggest characteristics of AFib. Got to assess the patient, determine if they are in RVR, make sure that their heart rate is controlled so that cardiac output is adequate. Always monitor them for signs and symptoms of stroke. We got to prevent a stroke, and the only way we can do that is by making sure they're taking anticoagulants, so hopefully clots don't form. Treatment, medications, beta blockers, calcium channel blockers, anything to control the heart rate, cardioversions if we got to convert them back to a normal sinus rhythm, and ablations. So I hope that you guys have enjoyed this lesson and are more comfortable identifying AFib on an EKG and understand the nursing interventions to prevent complications. Make sure that you guys check out all of the resources that are attached to this lesson, and make sure that you guys go out and be your best selves today. And as always, happy nursing.